Thanks everybody for joining. And I'm so delighted to introduce you all to Dr. Mehra Golshan. He is one of our new Yale breast surgeons. Mehra arrived at Yale in June of last year, sort of in the midst of the early pandemic. And he came from the Brigham in Boston, where he was breast surgeon and a leader there. And at Yale, among his many titles, he serves as the deputy CMO for Smilo's Surgical Services. And he's got some other titles as well. He just recently relinquished his role as interim chief of breast surgery. He's been recruiting breast surgeons, several of them, including our new breast surgery chief, Dr. Rachel Greenup. So that's a new era, I think, for breast services at Yale. And among Dr. Golshan's many interests and talents, he's working on novel intraoperative imaging techniques, focusing on MRI and the OR. So he'll be sharing his experience and knowledge on this topic with us today. So thank you very much, Mehra, for joining us, and it's all yours.
Thank you so much, Regina, for the kind invitation, and Dr. Goodman as well. It's been a great transition here to Yale, and I'm always a little hesitant at talking about radiology to radiologists, especially from a surgical perspective. But I think this will be fun to go over a little bit of the work that I did at the Brigham and Farber, and how I'm trying to bring some of this here to Yale. Certainly for disclosures on funding, I had two NIH R25 fellows. They were actually surgeons who did image-guided therapy or radiology research for a couple of years, and we had a P41 grant for the NCI-GT at the Brigham and the Breast Cancer Research Foundation. Wanted to go over a little bit on where we stand in breast cancer, just overall, very briefly in 2021, some of our current workflow and challenges associated with that. I'll get to what Amigo means in a little bit, and some future directions. So super simplifying breast disease or breast cancer, this year there'll be about 2.4 million women worldwide who will be diagnosed with breast cancer, about 250,000 in the United States. Whether you use a combination of physical exam imaging with mammography, ultrasound, and or MRI, a biopsy to determine that the patient either has a malignancy or something that requires excision or not. Then we get them to the operating room if it needs to come out. We can use palpation if there are larger tumors, but we usually have a pretty well-screened population here in the United States. Certainly over the last several decades, clips have been used in the United States and many parts of the world to identify the site of biopsy. So if we need to go back our radiology colleagues have that target to go back to. The wire has been the primary method in breast surgery, although SEEDS, TAG, Savvy Scout MagSeed, and several other technologies are out there. And again, what we want to do is to remove the abnormality of their tumor, usually with surgery, and it's usually followed by adjuvant therapy, chemotherapy, endocrine therapy, targeted therapy, and when appropriate, radiation. If it's palpable, it's easy. Don't have to call you guys for help. But as I said, we have a very well-screened population in the United States, certainly along the East Coast and corridor, and most of our tumors are non-palpable. So a clip is placed and provides a target. Wires, which have been the primary method of localization when I first started training, and certainly when I first started at the Brigham, have numerous challenges. There have been dislodgement, migration, transection. When I say difficulty, schedule, or delays in operative time starts, usually the OR starts at 7:30, and I would never imagine calling Dr. Hooley or one of our colleagues in breast imaging to come in at 5:30 to put in a wire to get a 7:30 start. And we don't always have cases that are amenable to first starts that don't require localization. One of the exciting things that we probably won't go over in this talk has been that we've been switching over from wire localization to tag localization from Hologic, and that has kind of been allowing us to start at 7:30 when necessary. And disassociation of the localization with the surgery, I think, long term will provide a lot of benefit to our patients, and in terms of scheduling, both surgically and in radiology. The margin dilemma, when I first started, what's a clear margin? That target continues to move. It started with me at least at 5 millimeters, then it went to 3 millimeters, 2 millimeters, and now it's no ink on tumor for invasive breast cancer, and what we think is 2 millimeters for DCIS. We use the localization to identify the site, and then we confirm that it's removed with a specimen mammogram that shows hopefully the clip in the target. We can look at these two-dimensional images, and there's kind of various ways of trying to figure out, did we get it all out? But the gold standard is final histopathology, and that takes a week or two to come back. Yet we do know that positive margins contribute to an increase in local recurrence rates, higher re-excision. In fact, it impacts overall cancer mortality. There is delays in additional therapies, whether it's adjuvant chemotherapy and or radiation. If you have to do additional surgery, removing more breast tissue leads to diminished aesthetic outcomes. Certainly higher infection rates also lead to a diminished aesthetic outcome. And there's an increased cost, and it's a negative psychological impact on the patient, telling them that they have to come back again for another operation. We've actually published, and other groups have, a higher mastectomy rate when there is a need for re-excision. And the challenge is that really there is no reliable intraoperative way of telling if a margin is clear in breast surgery in real time, and re-excision rates in the literature vary anywhere between 15 and 40%. And what I'm going to go through is kind of like a body of work that I've been working on for about a decade and a half now. And it's really to de-escalate therapy or surgery, yet at least at the beginning, you're going to think that I'm actually kind of overdoing some of the therapy before we get to the point of de-escalation. And I promise you we'll get to the answers to this. In terms of surgical planning and workflow, we could consider giving drug therapy upfront to decrease the tumor size and potentially, achieve clear margins a little bit more easily. Yet, if we're going to go down the route of breast conservation, the incision placement is also going to be very important in case we're not able to achieve clear margins and the patient needs to go on to a mastectomy. There are limitations in terms of the imaging that is done for us for the time of surgery in terms of wire localization or tag or seed localization. And at least when I started this body of research, every breast MR that I know that has been performed in the world has always been in a prone position, yet I've never actually operated on a woman's breast prone. It's always supine. And this breast MR, tumor deformation and tumor location, the breast is not a fixed organ, and we'll see some of the differences if you do a breast MR in the supine versus the prone position, at least in the operative setting. And all this really kind of leads to challenges in margin assessment. So we're going to get to this Amigo OR, which stands for the Advanced Multimodality Image Guided Operating Suite at the Brigham and Women's Hospital. But before getting there, I really have to talk about a radiology colleague of mine who unfortunately passed away unexpectedly and too early, Ferenc Jolez, who was the head of MR at the Brigham. He's originally from Budapest in Hungary. He trained as a neurosurgeon, but came to Boston and then did his training. He was smart. He became a radiologist, did training in radiology and neuroradiology. And his vision of image-guided therapy, which is something that really anyone that worked with him and in our program in the NCIGT, was to enhance the eye with multimodality imaging, helping the surgeon replace his or her hand with image-controlled devices, how to integrate therapy with intraoperative imaging. And this is just not in breast cancer, we'll see in many other disease processes. Develop image-guided therapy delivery systems in multiple clinical applications, and really change invasive procedures to minimally or non-invasive, and again, getting to this point of de-escalating therapy. A little bit about the image-guided therapy program, which preceded preceded me starting at the Brigham with the MRT in 1991. And I'm really going to kind of fast forward to 2005 when there was a P41 grant that established the National Center for Image Guided Therapy at the Brigham. And then this Amigo operating room, which was the first operative suite to offer both intra-op PET, CT, and 3 Tesla MR, ultrasound, fluoro, angio, and actually intra-op mass spec as well, was in 2011. I was fortunate to do actually the first case in this Amigo operative suite in 2011. And in 2021, the P41 grant was re-awarded a new grant, and this is now led by Claire Tempany, who's a phenomenal radiology colleague of mine, and a lot of that work that I started continues at the Brigham, which we'll discuss. The goal of Amigo is not to build some very fancy operating room in the multiple of these around the United States because they're very costly. But it is to test ideas in this operative suite and how can we bring it to the real world. So looking at imaging guidance, therapy delivery systems, whether it's an image guided surgery, tumor ablation, which there were a lot of procedures done, or in image guided endoscopy, and really a training and educational platform to test this in Amigo and then bring it out to the quote regular operating rooms. This operating room sat under 75, two stories under 75 Francis Street in Boston. And again, there was a 3 TMR, an operating room, and a PET CT, and we'll kind of go over how that ended up functioning. And this little short video will show. So this is 2 stories below the Brigham. The operating room's in the middle. On the right is the MR, which weighed about, I think they said about 11,000 pounds, that would come into the OR when necessary for us to do intra-op MR. The MR would pull back, and then again in the room on the other side was the PET CT. So Amigo 1.0 for breast was, is it actually even feasible, or has anyone actually ever operated on the breast with an MR? And I really couldn't find anything out there in this area when I first started. Certainly, I had to kind of figure it out myself, meaning that there was really no operative equipment for me to use that was MR compatible that breast surgeons usually use. Didn't have an MR coil. Actually, I've jimmied a cardiac MR coil for the breast coil to utilize it for this breast surgery. So we really wanted to show, is it feasible to even do breast surgery in a safe, sterile manner? What was the duration of the procedure and image quality? So again, this is a phase 1, just feasibility trial. We enrolled 15 patients. 3 were excluded because when they got their diagnostic MR, the extent of disease precluded breast conservation. So these were candidates for what we were considered for intraoperative to undergo lumpectomy and not mastectomy. So there were no complications, no safety issues, no sterility concerns. And our mean surgical time was 114 minutes. And I know that may sound excessive, but actually we were able to, after the first 2 cases, really bring the OR times down to what it's about 95 minutes right now at the Brigham. So you would think that I'm doing the same surgery I am, and I was actually able to do 2 intra-op MRs along with the lumpectomy and sentinel node. We're now down to 1 intra-op MR, and I'll talk about that as well. So our historical re-excision rates at the Brigham were up to 41%. This was even before I started. With Amigo, again, this wasn't the primary endpoint, but the re-excision rate was 16%, and those were really for 2 cases of DCIS, and there were really no positive margins for invasive breast cancer. And this was actually at a time where it was actually a 2-millimeter margin considered clear and not knowing on tumor. We published this, both the video of us doing it, but also in the breast journal, but also the pilot study in the Annals of Surgical Oncology. And one of the things that we ended up seeing was that early on was that the tumor overlays of the diagnostic breast MR done in the prone versus in the supine position where I operate was so dramatically different, meaning that, again, I think one of the challenges surgeons have had is that when we look at a breast MR, in my head, I was never flipping the patient from her stomach to her back and thinking of where that tumor would move. This is not like a fixed organ like the brain, where potentially being on your stomach or back may not make as big of a difference, and the breast is not a fixed organ. So you can see a lot of not only the location, but also tumor deformation when you overlay the tumors on top of each other in the prone position versus in the supine intraop MR. This was an early case of us, a diagnostic prone MR. This was the post-contrast imaging and some 3D volume rendering that showed the breast tumor. This was that same patient pre-procedure supine MR, and you can see that this tumor looks, at least to how I would approach it, vastly different. And it's a little vitamin E marker there as well. And again, the 3D voluming looked very different than the original image that I saw in the diagnostic setting. I would do a lumpectomy like I would in any other case, but what we would end up doing was filling in the cavity of what we resected with saline, which was based on the measurement of the tumor and the excision, temporarily closing the breast, doing an intraop MR, and then looking at the cavity for residual enhancement on around the tumor where we think that we may have left tumor behind. This is another case I actually did of a multifocal tumor, different view, obviously, 3D volume rendering showing the tumor, and then the post-procedure supine MR showing the surgical cavity afterwards. Another multifocal tumor of ours with a different rendering of the 3D volume prior to surgery. This is how it looks like when they are in the pre-procedure supine or operative position. So very different in terms of location. And this was actually one of the challenges we had, is you absolutely have to make sure you fill the cavity with the exact volume, or actually try to overinflate it, because the enhancement that you see if you don't fill it in with saline could be confused potentially with tumor. This is another video that it's a very fast forward version of what we do. But what we would do is we would do an intraop MR of the patient in this supine position. Then after this is done, I just approach this surgery just like anywhere else. We do a sentinel node biopsy. This is Claudius Conrad, one of our first surgical fellows, breast fellows. Then we do the lumpectomy like I would do anywhere else, get that thing out. And then once we resected it, we closed the lumpectomy cavity, filled it in with saline, and then compared the imaging pre and post resection, looking for potential enhancement. Then we would reopen, take shave margins, and then wait for final pathology. Sorry, I'm going to move forward. So multiple cases that we did. One of the big areas that Eva Gumbos, which was the breast imager that I worked with at J. Jagadisan, who was the PhD, was if you took multiple cases of tumor deformation and tumor position change in supine versus prone. So you can see multiple different cases of ours where if you overlaid the tumor in the diagnostic prone position to the operative supine position, yeah, this tumor is nowhere near where I'm trying to approach it surgically. And if you overlaid them, it doesn't actually look the same either. And we actually studied this in terms of volume, surface area change, the 3D diameter surface volume ratio, an entity called compactness and spherical disproportion and sphericity. And there was a large amount of change, no matter how much we looked at this in terms of the distance of the tumor from the skin to the chest or to the nipple, and the distance to the skin itself. We ended up publishing this a little while back in Radiology on the intraoperative supine breast tumor and trying to quantify tumor deformation and detection of residual breast cancer and preliminary results. So once we finish Amigo 1.0, we then design Amigo 2.0, which is actually a trial that's still open. It's a phase 2 clinical trial. Our target enrollment is 43 patients. And actually, before I left, we were at 33. We're now at 37 with Dr. Tan Barbie, who has taken over that for me. And we were marrying at this point intraop MR with mass spec. And the work of mass spec I was doing in parallel with Dr. Natalie Auger, who's a PhD at the Brigham, who I actually met in Amigo because she was working with our with our neurosurgeons and she was looking at mass spec distinguishing cancer from normal using spatial distribution, and in this case was an application of DESI, or desorption electrospray ionization spectrometry. And we were finding she was finding different intensities of lipid profile in brain resections of brain mets from breast cancer. So we then started looking at our mastectomy specimens ex vivo using mass spec, and this was not being done in real time. We published this in PNAS, and what ended up happening is we originally started with using DESI, or ambient mass spectrometry, kind of coming at it at an angle caused the specimen not to stay in its location, and its evaluation in real time ended up being pretty challenging. So we moved from DESI to LESA, or liquid extraction surface, or basically looking at the probe positioning perpendicular and not at an angle, which ends up being a lot easier for us to utilize. And again, we ended up publishing a second paper in PNAS on this. And the goal of Natalie and myself is finding a navigation system. Could we potentially find a device to use in real time using optical sensors and mass spec while we're doing the lumpectomy? And there's really two approaches to this. What we have been doing is an offline approach where I do the lumpectomy. I would be sending the shave margins, and then in real time, Dr. Auger and her group would be doing mass spec analysis and telling us the results if margins are clear or not clear. Or is there an online approach using a surgical handpiece connected to a mass spec device? And we're at this point of now using this a new mass spectrometry handheld device. This is actually pretty bulky, but believe it or not, this is actually pretty darn small in size, that we're trying to get smaller to be able to use mass spec with a handheld device while operating in the Amigo suite. So we did an interim analysis of our first 21 cases in the second phase 2 trial. This was a mix of different tumor types, ductal, lobular. Again, all these patients were undergoing breast conserving therapy, various grades of tumor, ERPR positive, negative, HER2 positive, triple negative. Certainly we didn't have a lot of HER2 positive or triple negative because these were patients that would often undergo neoadjuvant therapy, and neoadjuvant was actually an exclusion criteria for enrollment in our trial. But again, do the lumpectomy, send the margins, look at those margins in real time to be able to do an assessment. And again, our early results, and this is in press, which hopefully we'll be able to announce soon, is looking at the difference between normal breast tissue and tumor tissue is very different. And whether it's with lipid profiles and using Raman spectrometry, we were able to look at in real time, not the H&E, but in the mass spec world, seeing different peaks of whether it was lipid profile, glutathione, that were suggestive of tumor being left in place. So I should take more tissue while I'm doing that lumpectomy procedure. And if you look at Amigo overall, since it first started when I did that first case in August of 2011, there's actually been almost 3,000 cases done in this operative suite. Certainly it's mostly our radiology colleagues and neurosurgeons who have the bulk of the time there. yet this is a little bit older slide, but we were able to do a fair number of breast surgery and breast biopsy procedures there. And you can certainly see the extent of procedures that have been done in Amigo. So being able to slice a little bit of time there was really, really great for them to allow us to do that work there. The exciting thing is that at Yale is that there is actually an intraop IMRIS 3T MR, always used by neurosurgery. And, one of the things that I negotiated coming in was to be able to bring some of the work that was done at the Brigham here to Yale, although that hasn't started as our IRB continues to work its way through. So how do I get out of this fancy operating room and bring any of this to the real world and something that may actually be valuable to patients, and to try to look at de-escalating therapy? And this, again, goes to that whole concept of why are we doing the breast MR in the prone position, yet I'm always operating supine? And again, I showed you so many of the how different the tumor looks between prone and supine. And again, these are just a couple of examples of when you overlay the diagnostic imaging in the prone position versus the operative supine position. And on average, that displacement was about 7 centimeters. And what we wanted to do was, can we work with our radiology colleagues and surgeons, and actually in this case, radiation oncologists, to look at a trial that's being done outside of Amigo, just in the regular MR suites at the Brigham, at the Farber, in our patients undergoing neoadjuvant therapy. So we have a second phase 2 clinical trial that's open, looking at supine MR in breast cancer patients undergoing neoadjuvant therapy. The background for this is that, we often give neoadjuvant or drug therapy up front to shrink tumors, to potentially originally was to either make mastectomy patients who were not eligible for breast conservation, possibly breast conserving therapy cases, and then certainly to be able to do a smaller lumpectomy if we can shrink the tumor. There are some challenges with post-neoadjuvant imaging estimates of residual tumor and then how it works in surgical planning. I think there's a lot of room for improvement in this setting. So we wanted to look at the accuracy of supine MR for estimating tumor size prior to neoadjuvant and then after neoadjuvant therapy, to better characterize the difference between the supine and prone imaging, to look at surgical benefits of supine MR in terms of planning and re-excision rates. And where I think our radiology colleagues found this, and it'll be great to hear from those in the audience today, is that when you look at the prone breast MR and you're trying to do an ultrasound correlation, well, you're doing that ultrasound correlation not in a prone position, but either in this recumbent or reclining position or lying on her back. And whether actually, if you had the MR images and trying to do that correlation for that finding in the ultrasound setting position, that's a little bit more in line with the way the MR is done in supine, is that going to be a benefit to the radiologist? A little bit hard to see, but we were looking at newly stage invasive breast cancer, non-inflammatory. They would get a diagnostic MR with a targeted ultrasound, and then that were going to be considered for neoadjuvant therapy. We got a pre-neoadjuvant therapy MR both in the prone and in the supine position. The extent of disease was evaluated, and if there were findings on MR that weren't seen, they would get a second look ultrasound and then obviously supplemental views and biopsy if necessary. The radiologist would then do a survey asking if it was useful to have that MR in the supine position for their second look ultrasound. Patients would receive their neoadjuvant therapy, and then post-neoadjuvant, we would repeat the imaging, and then the surgeon and radiologist would do the tumor localization. We started with wire, but switched over to radio seed prior to surgery. Again, the radiologist would complete a survey prior to determine if that imaging was helpful. They would undergo breast conservation or mastectomy, and then look at margins and look at final pathology. So this trial is actually it's about 60% finished accruing. It'll be interesting to see what the results of this are. So I guess I go back to this vision of image-guided surgery and Dr. Ferenc Yoles, and honestly, if it wasn't for him and taking me in early on as a young breast surgeon at the Brigham, trying to figure out what I could do in terms of research, and you really go back to enhancing the eye with multimodality imaging, helping us replace the hand with image-controlled device, integrating therapy with intraoperative imaging, and then developing these image-guided therapy delivery systems for multiple clinical applications. And as you saw, there were about 3,000 different types of procedures done in Amigo. And breast surgery was just a small sliver, but there were thoracic surgery, neurosurgery cases, GYN oncology, and obviously our radiology colleagues, and really changing our invasive techniques to minimally invasive ones. And really his goal, he was always saying, is Mehra, you got to get out of Amigo, meaning you find something and try to get it out to the real world. And I guess the final thought is for those trainees that are here is really to build your research step by step, question by question. And then this was when my son was much younger, an earlier snowstorm in Boston, trying to shovel my car out to get to work, but always keep a shovel handy, because once you figure out what you think you're doing, something else piles on. So with that, I really thank you for the privilege of talking to my radiology colleagues. I know this is an area that you guys know much better than me, but it's been really fun collaborating with colleagues in real time in the operating room, and I'm hoping to do a little bit of this here at Yale. Thank you.
Thanks, Mehra. That was great. I think if there are any questions, it's probably best to type them in the Q&A box. I believe that's the best way. And while people are thinking of questions, I have a couple. Where do I start? So I'm just curious, when you are looking at the margins after you've done your initial resection, how do you know that any areas that look abnormal are not just inflammation from the surgery versus residual tumor?
Yeah, and that's where, it was relying on our radiology colleagues and to be able to tell us whether that was, as you said, was that like edema, inflammation, blood, like what was causing that afterwards. And again, the first phase of Amigo was that I do the lumpectomy, we do the MR, the radiologist would say, you know what, I see enhancement medial or posterior or anterior, wherever it was. I'm worried that this was tumor. But then when we would reopen, we would take all 6 shaved margins and then correlate the findings on those shaved margins to what she felt was the whether there was tumor, yes or no. And over time, we were able to kind of figure out what was related to damage that I was causing surgically versus what was potentially remnant tumor. It's not perfect, but I think we've gotten a lot better in doing in identifying that post contrast enhancement and trying to correlate that to tumor versus not.
Okay, great. Here's a question also from Dr. Goodman. Great talk. Are there any predictive modeling tools being worked on that can illustrate a virtual image of what a prone breast MRI would look like supine?
Yeah, so that's actually work that is being done, and it was kind of a model that was just being started by Jay Jagadizian, again, who's a PhD in Claire Tempany's group back at the Brigham. And it was just starting when I was leaving. And then a lot of things kind of also froze because of COVID, but it's actually something that they are restarting to look at now. Nothing yet ready for prime time, but I'm sure they'd be, love to share some of that work that's being done here with us, or maybe even definitely. And in fact, when I was getting some of those slides of Dr. Yoles from Claire Timpany, she actually made it very clear that, if there are people, colleagues in radiology at Yale that be interested in collaborating, it'd be great to be able to do something like that.
Okay, good. All right, so from Armanda Vesta, one of our trainees, thank you for the awesome talk. I can imagine that when we switch from prone to supine MRI, the correlation with ultrasound will become easier since we know that ultrasound is done supine. But correlation with mammography becomes harder because of the compression in mammo. So is the ultimate goal to get rid of prone MRI?
No, I don't think it's the ultimate goal is to get rid of prone, and I don't think that'll ever happen. Yet I do think that most of the correlations that we're, and again, Dr. Hu, you'll be able to answer this much better than me, is that, you know, you're going to usually look with ultrasound first and not mammography again. And then if you can find it on an ultrasound, you do the core. And then if not, then you'd have to bring them back for the whole rigmarole of MR core, which I'm sure is, at least from what I've seen, not nearly as kind of maybe easy as the ultrasound core. I do think the reason why we chose neoadjuvant therapy as opposed to just newly diagnosed breast cancers is because we always struggle with a couple of things in the neoadjuvant setting. You know, what is, you know, residual enhancement or not? What is tumor or not? And we thought that getting both the supine and prone imaging, both pre and post neoadjuvant therapy, would be able to answer a little bit more of those questions for us. And then there was a criticism of, you know, how much time this is going to adding the supine MR sequences in the regular workflow. The techs were able to, we ended up adding about 15 minutes to the study in terms of turning the woman from, you know, lying on her stomach to the back to get those last sequences done. So certainly, you know, it's something you'd have to build into your, you know, the workflow to be able to do. And, you know, outside of a clinical trial setting or, you know, a research question, it's definitely not ready for prime time.
Okay, great. So they are done, if you're doing the prone and the supine, they are done at the same session, just.
They are. Then we ask the patient to turn over and do the supine one, which, you know, we actually had one. Yeah, it's not, I mean, it's such a, you know, it's not like a quick test to begin with. And there's a lot of, yeah, you have to have everyone on board. You have to have your techs, your protocoling, you know, and these are obviously areas that you know, you would know better than we would. But again, we got buy-in early on. You know, these are booked as a specific type procedure that then, like, you know, turns on the radar screen. And we only did it at 2 of our breast MR sites. One was at the Farber, one at the Brigham, to make sure that, you know, when it was being ordered, it was being done correctly.
I think you almost need a table that rotates for the patient so that then you can get the contrast, you know, as close as possible, so you don't have to worry about the dynamics.
Yeah.
So actually, my big question is this, because, you know, I ultrasound is my favorite imaging modality. And I'm wondering, I would assume that the Amigo suite has some ultrasound. And has anybody looked at intraoperative breast ultrasound beyond B mode and just looking at the tumor bed and the tumor, perhaps using a 3D probe and contrast with, you know, fancy tagged nanobubbles that will go directly to the tumor? Because it seems like that would answer your question for supine versus prone scanning. And I would think it might also be a little bit less expensive and quicker to do.
Yeah, you're right. I mean, so no one that, at least we didn't look into that while we were doing our project. Although you're right, it's at the end of the day, you know, this is, you know, it's expensive. We're not building these ORs, you know, left and right. But the whole goal was, like, you know, while we were testing these, you know, whether MR was prone supine or use mass spec, you know, and yes or no in margin assessment, can we, you know, develop that little special box to be able to find tumor in real time? It's more like utilize this suite to test those ideas and then bring it out to something that could be done in, you know, any OR anywhere around the country or around the world. And, you know, there have been a few things that have been able to come out of Amigo in thoracic surgery. And again, this one protocol in breast that we're doing, in the neoadjuvant setting, is, utilizing regular equipment. So ultrasound would be, as you said, much probably cheaper, faster, and better. But no, we didn't do that.
Yeah, we don't know
I'd
really
love to do that.
sensitivity.
Yeah.
It's just really theoretical, but
It'd be fun.
yeah. Okay, I think that might be all the questions that we have, but that was a great talk, Dr. Golshan. Thank you so much. It's exciting to see what the future has in store for us and our trainees as well. So, and our
Well,
patients.
it'll be fun. And again, I was try to be careful when I'm talking to radiologists about radiology. You guys know way too much more than I do, for sure. And but it'll be fun working together, and hopefully this will bring some ideas, beyond the the neurosurgery work that's being done here at Yale with the equipment they have. I think it really can open the door to a lot of other exciting projects.
Okay, thank you very much.
Awesome. Thank you. Have a great weekend, guys. Take care.
Bye.